Hello everyone, this is Holly Lemaster. I'm the Program Coordinator of the Colorado Mesa Initiative. Thank you for joining us on the webinar today. I would like to go through just a few housekeeping items before we get started. I want to just point out your GoToWebinar control panel. This is probably floating on the right side of your screen. If it's covering up your slides, you can minimize it by clicking on the little orange arrow. If you're having trouble with audio, you may be able to hear us just fine right now through your speakers on your computer system. If you are having difficulty hearing, you can use your telephone also to dial in. You received an email prior to this webinar that would give you your login information and your access code, so you can refer back to that email and go ahead and log in through the telephone if you're having trouble hearing us this way. You are all muted, so we are not able to hear you, and hopefully all of you can hear us. You can ask questions by clicking in the question box in the control panel, and we will be addressing questions at the end of the webinar. So once again, if you're having trouble hearing us, dial in on the phone. I want to let you know that there are handouts available for this webinar, a copy of the slide presentation that we're using today on the Colorado Mesa website. You will need to sign in to the website and then go to the events section and then upcoming webinars, and you'll be able to find the PDF of the handout. And as of Monday, we will have the archive of this webinar posted on the website. At that point, you'll be able to find both the recording of the webinar and the handouts under the classroom section and under webinar archives. And you'll also find the archives of all of the other webinars that we have done as well. So moving on to today's workshop, it's going to be conducted by Dr. Donald Murphy and Mike Lockwood. And I will turn it over to Dr. Murphy and have you introduce yourself, sir.
Yeah, thanks, Holly. So I'm Don Murphy. I'm a geriatrician who has been working in the Denver area for the last 20 years. Work with our group called Senior Care Colorado, IPC. With me is Mike Lockwood, who is our veteran physician assistant. Mike and I have been doing this together for almost 16 years. So we're going to do a bit of a tag team today in terms of addressing the key issues.
Howdy.
There you go.
Welcome, Mike.
Let me just introduce those of you who are not familiar with MESA to MESA. MESA stands for Medicare Experts Senior Access. Our goal is to help primary care providers throughout the state be adept at Medicare coding and documentation, really so that you're paid fairly for your work and that you are more likely to embrace the senior population. We want you to be comfortable serving patients with dementia and other geriatric syndromes. We know this takes a lot of time, but it is fun and rewarding work, and we're doing everything we can to try and encourage folks to embrace this kind of work. This is a collaboration funded by the Colorado Health Foundation, the Kaiser Permanente Foundation, and Caring for Colorado. We work in close association with the Alzheimer's Association Colorado chapter, and as I mentioned, it is our primary care practice, Senior Care Colorado, IPC, who provides the faculty members for MESA. In today's webinar, we're going to focus on practice management and time management techniques that we've learned and have implemented over the last couple of decades, really. We want to illustrate how to implement these principles in a busy primary care practice. We're going to focus on the team approach to geriatric care, effective and empathetic time management techniques, and tips and techniques for working in the field. By that I mean out in nursing homes, both skilled and long-term care, in assisted living facilities, and even in home visits. But first, let's just do a quick review of what we'll call the art of geriatric medicine. Now, we do have a webinar archived on this, so you can get to that and have our much more details. But today I just want to emphasize a few highlights of that. One is that you really do not have to be a board-certified geriatrician or internist or whatever to practice good geriatric medicine. Whether you're a family practitioner, internist, physician assistant, nurse practitioner, the key is that you have an underlying passion for taking care of seniors. And we have found over the years that the initials behind the name don't matter nearly as much as this underlying passion. And then also, there is a bit of a unique approach to primary care when we're talking about geriatrics. We focus more on maximizing function and quality of life. We have to do a better job, we believe, in balancing potential benefits with potential risks of tests and treatments. And we try and keep the patients we serve in their home environments as long as desirable, whether that's individual home, assisted living, wherever it might be. Okay, let's move now to the team approach to caring for seniors, and I am going to ask Mike to help lead our discussion on this one.
First a little bit about me. I was really lucky when I started geriatric medicine. It was in the days where productivity didn't really matter, and I was paid for by a hospital instead of the practice. So I was benefited by like a 4-year fellowship with Dr. Murphy, and I learned how to be a team member with a master delegator. So it was a good learning time for me. The members of the team, as most of us remember the patient, and but the family members. But I think the key for me is that every person in my office or the nursing home that I'm at or the assisted living is an important team member. Whether it's the social worker or the dietitian or the CNA or the nurse, the director of nurses, they're all as important. And I found that I get a lot of information in the nursing home from the CNAs. They're often the unnamed person that's doing all the dirty jobs, but they are with that resident more than any other person around. And if somebody's having a change in condition, a change in their memory, anything that's going on, if the CNAs know you and you know them by first name and you guys have a relationship, they will come to you directly and let you know who they're worried about. Teams are always tough. Different people have different personalities, and sometimes mine doesn't mix with theirs very well. But what I've learned is that's their business, and what I try to do is focus on what's best for the patient and not what's best for my personality, and that I need to be treated different than someone else. I think if I go to work with the mindset that we are all equals doing the best we can to take care of each individual resident, we don't end up with those kind of conflicts. I am ex-Navy, and so I think about navigators and captains of the ship, and I look at my role as being the navigator and trying to explain to the patient where we are, to the family, what my and our team's evaluation of the best options. However, it's really the patient that makes the decision. And I think when I tell people this, either the clinic or in the nursing home, the families, they're more inclined to tell me when they're going to be non-compliant, when I suggest something that they just can't do, whether it's fluid restriction or a new medication that they look at under the internet and they're afraid of. They come back and tell me so we can make a different approach, instead of me assuming they are taking something that I've written for. Sometimes our elderly seniors, we just don't hear what they want. And a lot of times the families will speak over what the family wants. And I've had patients that really don't want anything done except to be allowed to live as comfortably as possible. And it's a daughter or a granddaughter or grandson that really wants anything done, and then I see it as our role to get in and facilitate that conversation so we can all get on the same page. I also try, every time I talk to a new patient, I try to, as I get the history, try to get something where we're connected, where whether it's we visited the same place, something personal that attaches us together, and I also try to make sure we spend enough time together where they can develop some trust.
I would just add, Mike, that you point out that often we are mediators between patients, even those that have some degree of dementia, but are able to express their preferences, and the families that might have a little different viewpoint. And it's that mediating role that, at least to me, is half the fun in geriatrics. The answers are not that straightforward, and the time we put into helping the families, because we do take care of the caregivers like we take care of the patients, to come to some good compromises that everyone can live with is a big fulfilling part of this.
Yeah, and we also talk about I like to think it about a pendulum, but when we do the MOST document, and we try to do that on all our patients now, but to talk about advanced directives and what they want in life, I try to make sure they understand that this is as the time is right now, where you are right now medically, and that pendulum swings on what you want with care.
Exactly. Let me also pick up the need to find out where the individual patient falls along the spectrum. And that is, no matter what kind of testing or medication we're using, particularly if we're talking about prophylaxis, helping to prevent something versus medicines to relieve symptoms, we find a big spectrum of seniors who on one end say, hey, do everything you can, even if there's a small chance of it helping to prevent something, going all the way to the other end of the spectrum where say, no, I really don't like taking medications, and unless there's a big, big chance of it helping me, please don't bother. But it does behoove us to take the time to figure out where the patients fall in that spectrum. And again, we have to tie the family in with those discussions for most of the part two. Speaking of family, take it away.
Yeah, I think, the family, geriatrics is a lot like pediatrics. Sometimes the biggest challenge we have is not the patient, but the families. And I think that if you develop a relationship with them early and listen to their concerns and make sure we educate them on what the patient has and what the facility, if they're in a nursing home, or the caregivers that they're still living at home need, that we can create an environment that's going to be the best for everybody involved. The most difficult time is when we have 3 or 4 different family members that are having no agreement on where they want to go. And I think there was a webinar done previously on how to make everyone get their wishes known and those kind of things. But what I try to ask the family to do is give me one person to talk to. We do have limited time, and we're going to talk a little bit about time management later on. But for me, if I can pick up the phone and call one person and talk to them, I can have time to do that. But if I have to call 4 people, it's just not going to happen in the kind of practice that I have. And so I try to have that conversation early on.
And they're respectful of that. I mean,
almost
the vast majority understand the need to have that kind of improved communication.
Certainly HIPAA can become an issue, and you just have to make sure you know who the POA is and make sure you have permission to talk to every other people. My personal viewpoint is HIPAA is probably the worst thing that's happened to medicine in the last 20 years, but I don't know how everybody else feels about that.
Well, I would, yes, I agree. I don't know if I'd put it exactly like that, but I would say that we ought not be hamstrung by perceptions about HIPAA. Do the right thing, and yeah, recognize that there are gray areas, and it's not going to be clear-cut in a lot of cases, and you do the best you can.
The last thing is when we discharge somebody from a skilled facility, we make sure we communicate to the clinician that is responsible for them and along with the family. What we do now in our practice is we have a discharge summary that's completed by the physician or NP or PA that discharges that resident, and we fax that to the office of the physician responsible for them so that we know that they know what went on, and give them our number so if they have questions or want follow-up, they can get back in touch with the providers that took care of that person. Goes back to the communicate, communicate, communicate. It's not only with the staff in the facility, it's with the folks that are going to be responsible for those patients that come out. It's awfully frustrating, and I'm sure you guys have experienced this, when you get a patient in a skilled facility that's not your patient, and the discharge summary from the hospitalist comes to you 10 days later because they met their requirements by the hospital to get it done. What we like is some of our hospitalists will call us and talk to us when they discharge somebody, and that's really helpful. We try to do the same thing to our folks on it.
Right.
Sorry.
And let me just add on this in terms of communication with all the players involved, particularly in our nursing home. Number one, when you go to those that really know the patient, as Mike said, they will respect you more, you will have more fun, you'll get better information. Number two, and we'll direct you to our webinar on time-based billing. When you are billing based on time in a facility like this, all that time you have discussing with various caregivers and what have you counts. So that you need to know how to capture your time so you get paid fairly for the work you do.
In the nursing staff, I've got terrible handwriting, so it facilitates me in talking to talk to nurses, because I show them every order I write I go over with the nurse. so she knows what I've written, because it helps my time management, because I don't get a call later on trying to explain what I did and spend time with that. It also gives them a chance to participate in the decision making, and I ask them, what do you think we should do? And even if I don't agree with them, we again try to collaborate on the treatment plan.
That's key, absolutely key.
And that's not something I did when I first came to geriatrics. I was not known for that 15 years ago.
Okay, Mike, talk about the relationship between the doc and the mid-levels.
I've changed. Don has been my supervising physician for the whole time I've been here, but I work with a lot of different physicians, and sometimes I describe the practice as an allied health provider as being schizophrenic, because I try to be flexible in my approach to patients to meet to practice like the docs I'm working with. That's how I think PAs were established, as an outreach of that doc. I think they have to trust my decision-making process. So when I get a new physician, I'm more inclined to call them more often, to send them emails, to communicate with them what's going on with patients. And as they begin to trust me, they'll give me the feedback that I'm communicating with them too much. It's also, I think, important to make sure your schedules work together, that you both can stay productive in the facilities, that you are that there's docs in the clinic when you're there, if at all possible, because at least for us in the private payment system, we get that extra 15% when there's a physician in the office with us. So, and try to facilitate when that's not going to happen, so you know about it.
On the scheduling, by the way, that is key to what we do here in Denver and surrounding areas. And so for those providers out there that have some kind of office staff that can help you with that, it's a very, very good investment in your overhead structure to make sure you have someone that's keeping the docs and the NPs and PAs working together as a team, not tripping over each other, and covering the facilities.
And the last thing I have a doc said to me, a new doc I'm working with said to me that she doesn't do hints very well, that I need to be open and direct. And for her to, that's kind of the way I talk anyway, so for her to say that to me, it really improved our relationship from the beginning. So new physicians are bringing PAs or NPs on staff. It's really important for you to communicate to them how you want to communicate, how open you are to criticism. If you have a tendency to become defensive, let them know how you want it to be talked to. I think it helps everybody.
Let's now shift to the staff in terms of helping them understand the needs of seniors.
The bottom line is seniors. Some seniors want to be called by their first name. Some want to be called by Mr. or Mrs. Some seniors have a lot of accommodating issues: vision, hearing, neuropathies, gait abnormalities. The staff needs to know about what that's like. We've done training in our offices several years ago where you put on glasses with that you can't see through, and gloves and big boots, and try to walk around and see how fast you can get back to the room. And so it helps people understand that, so when they're taking somebody that has problems, they can get back. Again, ideal world, you ought to take a blood pressure 5 minutes after the patient's in the room. I think that may happen 2% of the time in our offices, so often I'll end up repeating a blood pressure if somebody's high, just to see what they're like when they're more at rest. We ask patients to bring their meds with them. We ask them to write down questions so that if they have questions for us, they can remember them and we can get to them more quickly. Sometimes it happens, sometimes it doesn't, but it certainly helps when it does.
And then your office staff, often because of their personal experiences or just their experience with seniors, will help educate us, the providers, on some things that can help our practice be a little more geriatric friendly. Okay, now we're going to go to some time management techniques. Taking good care of seniors does require a lot of time. And the one point here I would emphasize is that at some point in the history of your care of that senior, you need to give him or her and or their family a lot of time at some point. You can't expect to do that every visit or even the majority of the visits, but at some point they need to know that they have your undivided attention. You've done a good job of digging deep and addressing their concerns, and you're kind of triaging your time over a period of months, or if not year, or whatever. But it's hard to give good geriatrics if you're always kind of rushed and you're just squeezing them into 15-minute appointments. Sometimes you'll have to do that, but at least 1 or 2 visits, or however you want to structure that, make sure you give them the time. Mike?
You know, also for me, it's when you get the patient that's a talker or the family that's a talker, we have to figure out how to set boundaries, how to set expectations when they come. Make sure that, you know, what I do is I tell them, I said, I have 20 minutes for my appointment with you. And what are the 3 most important things that you want to talk about? Or what are the 2 most important? If they have an issue, for instance, like advanced directives or mom's got dementia, what are we going to do in life in the future, those kind of things, I'll say, come back next week and I'll see you, and we'll spend the whole time to talk about that. You know, I also, if it starts to get too long, I will say, listen, I mean, you're really doing well. I have somebody that's my next patient that's very sick. I really have to get to them. I need to stop now, and I'll see you back. But we can't spend till 6 or 7 o'clock at night trying to finish our schedule. Yet we still have to provide good care.
Yes, and we already covered the importance of spending at least some visits on that, but also need to emphasize that it is important to apologize when we're late. And, you know, we're late much more often than not. You might not have to do that if you're 5 or 10 minutes late, but when you're coming in 15, 20 minutes or anything after that, it's a good practice to apologize. You're showing the seniors and the families that you respect their time. You're doing the best you can, but at least acknowledge that their time is very important.
The other thing that happens in our office here in Aurora is that if I'm getting way behind, and I will ask my MA to check to see if another provider can see one of my patients if their schedule is not as tight, and ask the patient if it's okay. And often that helps them learn to meet other people in the team and can help me get back on schedule.
Now, in any setting, we know that some seniors are just going to require a lot more time. And so you ought to be a little more creative in your scheduling so that if you need more time with individuals, you're able to do that. And as we've said before, you really do need to become an expert at time-based billing. You have to know how to capture that time when indeed you're providing it. Okay, let's go back to the field, Mike, and comment on some of the pearls you have from that.
Well, for me, you know, the sheet here is just really pretty specific, but, you know, everybody's different. Everybody's different in our approach, and my approach is not necessarily going to be the approach that you need. And my major facility I go to right now, it's the culture that it's a self-pay facility, takes Medicare, doesn't take any HMOs, doesn't take Medicaid. So there's a lot of hand-holding with patients. We need to recognize that. One of the facilities that I used to go before that the families weren't really involved with a lot of the patients, and more of my time was spent communicating to patients than families. Also, the needs and cultures of each facilities will vary. I'm lucky right now, the director of nursing and administrator at the facility I've been there has been there since it opened. But if you get a new director and a new administrator, that whole culture can change pretty quickly.
Yeah. Key point, you know, just like we as providers have to know how to work with different personalities, same thing. We have to know how to work with different cultures in the facilities.
I think that, again, we're talking back to communications, I try to at least once a week touch base with the executive director. I touch base with the director of nurses on a daily basis to make sure that we are meeting the needs of what they want for their facility, and that we continue to get the majority of the admissions.
And we also understand that the difference between an urban setting and a rural may be pretty significant, but you know, you providers out there in the rural area know that it's very important to really work well with your staffs in the facilities. Let's just cover a couple of different approaches on how we make sure we're covering the needs in a facility.
Okay. One thing is about with calling families and discussing issues with families. What my approach is, I'm sorry, I'm on the wrong slide. I apologize. What I do in my facilities is I'm in this facility 5 days a week, So when I get there, I round each nurse's station, talk to the nurse, what's going on, what's their needs. I set my priorities of what the day is going to be and have a sense of how many people I need to see and who needs to see me. I take care of the urgent patients first, the ones that have significantly abnormal labs or have change in conditions, and then finish up with non-urgent patients, knowing that that changes. I can have a great schedule going, and all of a sudden somebody changes direction, and I have to spend my time with that patient. So I keep a record of who I've seen, so I know that when I go there the next day, we try to see skilled patients at least 2 times a week. And so this is a way to keep myself, and we share those between the physician I work with, so that we know by the end of the week that everybody's gotten enough time to them to make sure that we're meeting the needs of the facility. And what this facility wants from me is the ability, and from our team, is to make sure that the patient is healthy enough to participate in rehab and make progress and leave there better than when they came in.
And I would suggest that there are alternative approaches. For example, I might go in and cover a facility more geographically. I'll go to a unit, get a sense of what are the easier things that need to be covered, what are the more difficult ones, cover that unit, knowing that I have to leave enough time for subsequent units, and there will be those days when I don't get everything covered, but working with our larger team, I'm able to communicate with the other providers to ask them to follow up on other things. So different people are going to have different styles, but I think the key thing is, no matter how you approach it, you have to have a good sense of when you can really zero in and cover 1 or 2 problems versus the need to, spend an hour on a particular patient, and how to do that, how to balance those 2 very different approaches.
The other thing is communicating with families. So often the nurses have to call the families also, and you get a sense of which families want to talk to the clinician specifically and which one you can just ask the nurse to give them a call about a change in treatment plan. And then ask the nurse to make sure if the family has more questions, they let you know, and you can call them later on in the day.
Yeah, and we would suggest, although the law, so to speak, requires a minimum of every 2-month visits, the standard of care, at least in Denver, we believe in other surrounding areas, is really a minimum of once a month. That for this population, for us to serve them well, we ought to be seeing once a month. Call that a regulatory visit, realizing that there will be additional visits for acute problems that come up. And then, of course, you have to know that the mid-level can do the regulatory visit 1 month, the doc the next month. The acute visits, at least for long-term care patients, can be done by either the mid-level or the doc.
The other important thing, Don, is to make sure that you don't leave all your regulatory visits for the last 2 days of the month.
Right.
You start hurrying through them. At least for me, if I start hurrying through them, I may not pay attention to every some lab I need to order because it hasn't done. And I like it when the pharmacist reports don't have anything on them.
Right. Exactly. Now, working further in the field, home visits and assisted living facilities, whether you're talking small group homes or moderate-sized ALFs, those in our practice who do a lot of this will tell you that this is one of the most fun things we do, to actually take care of the patients in their homes.
Absolutely.
Tremendous service. We ought to be able to do that whether in a bigger city or in a small community. But the key is to have a system so that you can schedule these conveniently. If you're in a real small town and it's only 5 minutes from point A to point B, not a big deal. But if you're traveling good distances, you want to have these scheduled so that you have flexibility, but you're also able to make it convenient for you, the provider, so that you know how to get this done. And also the reimbursement for this is good and fair, and you need to know how to capture that. That's in a different webinar.
That is in a different webinar.
That's right.
Okay, that's what we've prepared for you today, and I'd like to just give everyone an opportunity. If you have any questions about what you've heard, you can go to your question box in your control panel and type them in. And I have one question here. What are the differences between PAs and NPs in the clinical setting?
Yeah, I'm one of the few PAs that went to a program that was a combined program with PAs and NPs. There was 2, the program had 2 years of that before it was stopped. And my belief is the education is close to the same. There are some variances, but 3 years out in the field, you will not see a clinical difference between a good PA and a good NP. There's some regulatory issues, but we have both in our practice, and I would put any the peers side by side with each other.
I would tend to agree. There are a few differences. In terms of the training, I get the impression that the NPs have a little more classroom work, the PAs have more field work, so might be in a little better position to jump in right when you get out. But you also have that regulation where the PA has to be pretty much hooked to the hip of a doc for the first 6 months. Not so much with the NPs, though they have their specific issue regarding prescriptive authority. So we work through both of those, but as Mike says, it doesn't matter whether you have an NP or PA behind your name. If you really like doing this work, you're committed to it. After a year or two, the differences have just melted away.
Thank you. Okay, the next question. How do you handle someone, whether it's a patient or, for example, a nurse in a facility who's a talker and always takes more time than you have?
You mean like, how do I handle Mike? You know,
That's why we're running over time.
That's why we're running over.
Go for it, Mike.
My favorite thing for a patient that's a talker, especially in a nursing home, is that saying, you know, I've got to go take care of somebody sick now, and give them a hug. And I end my time with patients is with a hug or a touch, and it kind of stops the process because my residents have gotten used to that. With a staff member, I had that happen today, and I just say I have limited time. I really appreciate that, and maybe we can talk tomorrow, and then just move on.
Yeah, it really is about gentle and sensitive ways of setting some boundaries. And people are very respectful of that. It's only in a very, very small minority where you really have to come down a little more strongly than you'd like to.
Great. Okay, we are at time, so we're going to move on to just a couple more housekeeping items. We want to just remind you there are so many resources available to you on the Colorado Mesa website. You do need to sign in as a user, but that is no big deal. I know a lot of you who are on the webinars are already users, but we just want to remind you there's a lot of great stuff out there. We have just posted yesterday, we promised some new resources on the annual wellness visit. So there is now a template that was created by the senior care practice, also with our Mesa audience in mind, that's available to you, as well as a sample letter that you can use to send to your patients about the annual wellness visit. So be sure to go and check that out. It's under the Documents and Links section. And there's much more good stuff out there. If you have any questions that you didn't get answered today, you can always go to the discussion forum and post those, and we will be responsive to getting those answered. Would also like to remind you that our next webinar is the first Friday of the month, as always. It'll be November 4th next time. It will be featuring Dr. Donald Murphy and Mark Grimm, who's one of our social workers here at the senior care practice, who is kind of a specialist in death, he tells me, and feels his name is appropriate for that role. And they're going to be talking about how to have those really difficult end-of-life decisions with your patients and their family members. So you can sign up for that on the website now. We hope you'll join us for that. Thank you, Dr. Murphy. Thank you, Mike Lockwood. We appreciate your time. And thanks to everyone who's joined us today.
Thank you.
Bye-bye.